Welcome to today's podcast and happy Pharmacist Month. I'm excited to have three pharmacy leaders and innovators join us today, Melissa Ortega, Staci Hermann, and Dave Hager, to talk about some of the major changes going on in the industry. So welcome, Melissa, Staci, and Dave.
Thanks, Jim. To those I haven't met, my name is Dave Hager. I'm a senior director here at Visante. I was in a variety of clinical leadership roles until I transitioned to Visante about a year and a half ago. And I'm excited to talk to two good colleagues and friends in Melissa and Staci. Staci, why don't you share a bit of your background for people who don't know you yet?
Happy to, Dave. Happy to be here. My name is Staci Hermann. I'm the Chief Pharmacy Officer for Dartmouth Health. This is a 6-hospital system in New Hampshire and Vermont. We also have a large community group practice about 90 miles away from our academic medical center. Prior to this, I have spent some time at Leahy as their Associate Director for Acute Care, spent some time at Tufts actually with Melissa as their Acute Care Director, or Pediatric Director, in IT, time at what was formerly known as Partners, leading their Epic install a few years ago, and really started my journey at the University of Kansas as their operations manager. So I like to tell people I've dabbled in everything. And what I often tell my residents is I still don't know what I want to do when I grow up. I will say what I enjoy most about being in this role is being on much more of the strategy side and business development and really pushing the pharmacy profession forward in a number of innovative ways. Melissa, I'll turn it over to you.
Fantastic. Thank you for having me here as well. And so nice to be with close colleagues. My name is Melissa Ortega. I am the System Vice President of Ambulatory Pharmacy Services for Tufts Medicine. Tufts Medicine is also a health system in the Boston area. We're comprised of an academic medical center as well as 2 hospitals, also have an integrative network, and a few other programs that I think we'll be able to touch on later on in this podcast. Prior to my journey as a system leader, I actually spent many years at the academic medical center in Boston, came there right after I completed my administrative residency out at Wisconsin, and took my first job overseeing acute care operations, and really spent a lot of time advancing the technology at the medical center. Like Staci, I've also dabbled in a few different areas. So from there, my career journey took me to overseeing our clinical programs, not only in pediatrics, but I also had the opportunity to start emergency department pharmacy services, and then also transitioned to leading our efforts with our outpatient pharmacy program. So championed dual accreditation with specialty pharmacy, really increased our clinic pharmacy presence throughout different specialties, as well as our community pharmacy practice. So really driven by advancing the profession and really ensuring and that patients have access to a pharmacist and pharmacy care.
It's both impressive group to be on the call with today. I wanted to focus on something you both mentioned to start, which is the fact that you have system pharmacy roles. We have seen across the country more and more health systems grow into larger systems, and with that brings a lot of change. And I think pharmacy ends up playing critical roles in that systemness approach. So as leaders in those types of large health systems, what are some of the unique challenges you deal with? Staci, let's start with your perspective and then we can jump to Melissa.
Sure. I will say when I first joined Dartmouth, it was not actually as the chief pharmacy officer. I was the system director for clinical pharmacy services. And the first project I got handed when I joined was to stand up a system P&T committee. And what was really coming to light, I would say, for our system in particular was the need for standardization. And IT was really driving that because we were deploying Epic throughout the system. And a core piece of that, right, is a standardized formulary and a standardized medication list. And so we really were, I would say, on the bleeding edge of trying to push forward into getting consensus agreement around what we were going to have in our EHR. And I still think pharmacy, to a lot of the extent, really is on that cutting edge service line for that type of integration. Flash forward a few years, P&T is still functioning, still running, but we're bringing more system members in, and pharmacy is often identified as one of the 4 components that needs to do due diligence around prior to that integration happening. And I say it's due diligence from the, what contracts do we have to change? How do we maximize savings in that space? But also the clinical integration piece, and making sure we can safely deploy Epic across the enterprise and make sure we're not causing problems as we do that with our standardization work. Melissa, I don't know if you've seen similar things or different things, just given your roles at Tufts.
No, very similar. I think just like Dartmouth, pharmacy was one of the first departments that was looked to bring in a structure from a system perspective. And what I would add on to a priority of standardization was also a focus for us, and my role was actually building programs oriented to serve patients within the system and not entity specific. So I was tasked with transforming a lot of our pharmacy programs, such as our specialty pharmacy program, to be available to all of our patients. And really studying where clinical practice was, or clinical programs, as well as our operational practices of what we can build upon. So that is oriented more from a system perspective and available to all patients versus one entity. And I think that's where the creativity, innovation, and collaboration really comes in.
And Melissa, I don't know if you saw this as you were doing and moving into the system integration piece, but at least at Dartmouth, one of the things I've most appreciated was being in pharmacy versus a different service line, because of the collegiality that we natively have within our profession. And so even though we were building what I would call as disruptors, because we were forcing some standardization to happen, we could pull the pharmacy leaders together and go, hey, can we all be in agreement on this? And inevitably, we could get to that consensus very easily of whatever it was we were trying to standardize. Whereas I feel like some of the other disciplines, they have more of a competitive nature, and it isn't as easy to necessarily get that integration because we're moving somebody's cheese and making it more difficult, because I may be moving patients out of one facility to another facility and having that kind of impact, or service lines out of one facility to another. I'd just be curious if you saw the same thing through your time at Tufts.
Yeah, very similar. And the other thing that I would add too, that I think is unique to pharmacy leaders, is just we speak many languages, right? So if you think about what it takes to build a new pharmacy program, whether that's contractual, licensing, collaboration with supply chain, buy-in internally from our department, we just naturally know how to collaborate and bring in other colleagues so that we can be successful. And I think with where pharmacy services has gone the last few years, and as we look at the pharmacy enterprise, I think we've become very multilingual in regards to really having those conversations across the system, whether it's with our system CFO, our VP of revenue cycle, or even with our providers. So I think that's also a really important component too, that I think adds on to our success from a pharmacy perspective.
Yeah, I think what you guys are both talking about is real cultural transformation and broader transformational change that is being driven by pharmacy leaders because of the multi-languages that they've been able to learn. And I think one of the things, to transition a little bit, that you both mentioned has been a topic of conversation between Dave Zills, or DZ, and I over the last couple of months, who I know we're all a little close to. He has talked about how pharmacy leaders now have squigglier paths than they used to, right? So it used to be like you kind of started in acute operations and you grew your way up, was a traditional model for leadership succession. But both of you demonstrated in your introductions that your paths were not maybe as linear and that you benefited from that. And that's probably where some of that multilingual capabilities come from. I guess, how do you guys think about our current pharmacy training programs and their ability to equip leaders for these types of system roles that you're in today? And do you think there are things that we should be thinking about adding, or things you've already added to programs at your sites?
Melissa, do you want to start?
Yeah, happy to start. Yeah, I'll talk a little bit about maybe kind of reflecting on my training and how that reflection has and my current career journey has also impacted the design of our current administrative residency program. And I think something that I really appreciated when I was completing my administrative training was just the exposure to the pharmacy enterprise, right? It wasn't anchored around acute care. We really were able to see pharmacy services throughout the continuum of care. So gaining an appreciation for that, I think was really, really important. So much so that I've seen it in my career journey, and it's built in as part of our program for the current administrative residents here at Tufts Medicine. So they spend ample amount of time with each of the directors, whether it's acute care or business director, ambulatory pharmacy, supply chain. So they get that exposure. Staci, I'll hand it over to you to add on.
Sounds good. I'm very similar in my appreciation for my training. The exposure is really what helped me, in addition to the network, right? And so even if it was something that I may not have been exposed to during training, there was the 1 degree of separation, it feels like, within our residency training program, that somebody knew somebody who knew somebody that could help, me talk through whatever the issue of the day was I was trying to evaluate. And I greatly appreciate that. Dartmouth actually just started their HSPAL program. We have our first resident in their second year this year. And the design of that program was very intentional to have some tie to the medical center because it's tied to that pharmacy department. But the majority of the leaders the resident is doing their training with are actually system leaders. They are actually based out of our Hooksett Shared Service Center, with right outside my office, actually. And so I am actively engaged in much of that residency program, even with my time and tenure as the chief pharmacy officer. I think it's vitally important to give the resident this type of exposure to the types of questions that get asked at this level and how pharmacy can be the solution to the health system problems that we're facing. My CEO has often said over the last year or so that she wants to diversify, the revenue stream for the organization. And, part of that from my perspective is, where does pharmacy fit? Outside of we're a cost center for inpatient or a revenue driver in the infusion/specialty retail space, but what else can we do, and how fast is the market changing for us to drive that? And I think the residents who currently are in HSPAL programs, as long as they're getting exposed to these types of conversations, are going to at least have the ideas planted as they graduate of where health systems are going, because healthcare is not going to look like today in probably 3 to 5 years. We are in a rapidly moving environment, and so the residents are going to need to be able to navigate that as they come out.
Yeah, Staci, and you bring up a really, really good point that I'm reflecting on in regards to leadership skills. I think the leader of yesterday is different than the leader of tomorrow. So when I think about those transformational projects, the ability to be very agile, creative, change management skills, the pace of healthcare, the pace of pharmacy is changing quickly, and you need to be able to quickly adapt and step into a position where you're empowering and leading your teams to really accomplish where you can be identified as part of the solution.
And I think, this dovetails into the next maybe challenge that we're all facing, which is the workforce shortage, right? And so how do you start to lead teams and the enterprise in an environment where, we used to have an abundance, right, of technicians and pharmacists, and that just isn't the situation that many of us are living in today. And so how do we solve that? I don't know if I necessarily have the solution yet, because I think it's all something we're all tackling, but it is definitely a challenge. And retention too is another big part of that.
Yeah, for sure. I feel like you're both touching on how important entrepreneurialism is in the training of our current residents. And I think that's interesting to kind of compare to, again, I think more traditional approaches that focused on like pharmacy leaders being great operators. And you're really talking about being real innovators and how they're going to need to transform some of their skills as they move forward in their careers. And it's probably good to start with how to operate, but then how they can move beyond that. I did want to go back to Staci's point, though, around workforce. Both of you helped with a recent white paper on the technician workforce shortage, and both of you had some program ideas to at least give to our listeners today some places to start. And where are you at right now for workforce, particularly on the technician side, and where do you see yourself going? Staci, maybe you could start with what you're seeing at Dartmouth Health.
Yeah, I would say a few years ago, actually, our HR department started what they call an apprenticeship program. And this was not unique to pharmacy. It was LNAs, MAs, lab techs, rad techs, basically all of the technical staff, if you will. And this apprenticeship program was partnered with a local community college. And so they have developed this program where, almost similar to the ASHP technician training program, we are sending technicians through these training programs, coming out where they can sit for their PTCB or certification courses. This has been wildly successful for us. In fact, our specialty program would not have grown at the pace it was able to without this program, because it was finding those individuals who may not have known of pharmacy as a career and brought them in and allowed us to grow and expand. Unfortunately, COVID has put a little bit of a damper on that, it just in general, and I know that has impacted many. And so where we have started to land now is looking at technology. So the hospital actually just deployed medication delivery robots as a means to help keep the technician staff we have doing activities that only a human can do. So they're in our IV rooms and they're, pulling things more in the central pharmacy versus running medications to the floor. And so we're trying to find that nice balance of where can technology help us, where applicable, and then how do we continue to retain while we're still working through the recruitment strategies with our training program. Melissa?
Yeah, I think our commitment to technician development continues. We're excited. I'm glad to hear that you had many successes with your technician training program. We're excited to be on that journey with a focus of really developing the technicians to have these advanced skills that we really need within our pharmacy programs. Jenna, you're gonna have to delete that pause. I'm sorry. I think something else that we are also having conversations about is, especially post-pandemic, is really evolving with the needs of the workforce. Yes, we have a shortage, but we're getting also different asks. And I think we're getting requests for more work from home. So now how do we build a practice model that really allows for that type of flexibility? And how do we sustain that? And then the other conversation that we're slowly starting to have, maybe a little bit more on the leadership team, is just where does artificial intelligence fit into this? And where can we really not only maximize on automation, but then how do we use the data that we have to really empower the work so we can continue to push and practice at the top of our license.
Yeah, I think it's good to hear you guys are finding some solutions locally and across the system. Tying it back to a larger system conversation, how has Systemness helped or hindered kind of approaches to the technician shortage? Staci, I was thinking about your program, like being an apprenticeship probably provided some ability then to draw from a larger geographic area maybe, or tell me more about how Systemness plays either as a facilitator or a hindrance to technician staffing.
Yeah, and maybe I'll start with the geographical area that Dartmouth actually covers. So I alluded to this a little bit in my intro. Our medical center is located on the border of Vermont and New Hampshire in northern New Hampshire. To get to the state line of Massachusetts and New Hampshire, it's probably an hour and a half to 2 hours away via highway. And we have a clinic on the Vermont side that is literally an hour from the US-Canadian border. So we cover a very expansive geographical area within our health system. And New Hampshire is one of the more rural states in the nation and one of the oldest states in the nation. So as we think about workforce challenges, some of the questions we've asked ourselves in addition to the apprenticeship program is, does this job have to happen here? And what we found is, many times inpatient pharmacies have just picked up jobs because it was asked of us historically. And the prime example I will give is clinic filling of medication requests, right? Not usually a high priority for an inpatient pharmacy. I can think of code cart tray filling. Does that have to happen there? Maybe, maybe not. And so as we developed our shared service center, we put that more centrally located in the system very intentionally, and then started moving out those non-required activities from the hospital itself. And by moving that shared service center more centrally to the system, it actually put us in a denser geographic area. And so we were able to recruit better in that area and more successfully. And so we've had some of those conversations as well of, again, what has to happen locally, what can happen centrally, how do we design this system to allow centralization of activities and more like a hub and spoke model, if you will. And that has really helped us as we've moved forward with our system integration work.
That's awesome. Melissa, anything from a system perspective? I love that connection to, hey, Systemness allows us then to really reimagine where the work is, to put the work where the people are, instead of trying to push the people to where the work is. What are you seeing?
Beautifully said. Well, we're very, very early in our journey in regards to discussions about a shared service center, but we're excited to at least be talking about it and really starting the design. I think where we have seen some successes of just having a little bit more of an orientation around a systems approach in regards to our workforce, it just allows us a little bit more of economy of scales when we think about training programs, right? We don't have 3 training programs that we're trying to implement. We have one that'll service all 3 hospitals. I think something else that we have been really excited to see is with different programs, there's different opportunities. So we actually have technicians that are growing within our system into different positions. And I think that's something really important. It's okay if they want to leave a team to grow within the organization. That's success in our eyes. So I think it falls back to really enhance our ability for career development, especially in some of those innovative and advanced roles.
Staci, do you want to build on that in terms of where your CSC fits into the bigger picture, and what other things you've combined with your CSC that have really provided value back? we're seeing a lot of people growing in that space, and it's fun how that just kind of organically came out of this. I'd love to hear more about what you're leveraging out of Hooksett.
Absolutely. When we went into this facility, it was an interesting building layout because the loading dock actually divided up two different warehouses. Warehouse spaces, not by our intentional design. It was just how the building was laid out. And so it allowed us to actually partner with supply chain to come into a building and start to develop both a supply chain and a pharmacy distribution model. Again, going back to that spoke and hub. The supply chain side of the house is used to dealing with delivery trucks day in and day out and dock management, which I was like, thank you for keeping that because I don't want to figure that out. And so, it's been more of an organic, natural partnership in that space. And as they've continued to grow in their journey for just different revenue opportunities, I've been partnering with them in those discussions on just different models. We are starting down our journey. So I mentioned we have centralized some of those activities out of inpatient. One of the things we have put in this shared service center is our clinic delivery of medications. But in that space, we are now starting to talk about repackaging. And repackaging for, critical access hospitals so they can buy the onesie twosie meds that they need, not the full-blown packages that only come through the wholesaler, and help minimize our waste. This central supply pharmacy is also starting to do inventory management across the system, and what drugs are about to expire. How do I get them out of that facility, pull them back, put them in a facility that has high volume distribution. So we are really starting to look at product movement and how all of that works. In addition, our home delivery for our specialty and retail site is in this building. So both of them are housed here, and that's been a great partnership because they're learning from each other and stealing and borrowing policies and procedures where needed, which is great. I think we are now able to likely continue to move into a central fill model. We have 3 different retail sites currently, probably going to expand that as the system continues to grow with our community hospitals. But again, I don't want to put 5 people, 10 people in a retail pharmacy if I don't have to, if I can fill all of those centrally using automation and ship the products out to those pharmacies for pickup. So what I would say is the biggest probably benefit of having this space is the actual space. We were not able to do all of these activities in a corner or in one of our pharmacies that was currently operating. There just wasn't enough space for it. And so having this space in this building is really the best benefit I see, because I don't know what tomorrow is going to bring. And so having the space to get creative with whatever the solution is going to be is really going to be important.
That's great. What I'm hearing is like you're really using the CSC to help catalyze some of the cultural transformation to Systemness. Not only is the space helpful, but you're driving home that message of like, we're going to think beyond silos and partner pharmacy and supply chain, and that's going to change the way we operate. And I guess, Melissa, maybe you could take that one step further. Like, we're trying to break down some of those silos, as as Staci said, being on that front edge of integration. Like, where are you seeing those divides starting to break down, like between pharmacy and ambulatory administration, or pharmacy and rev cycle, or specialty and infusion? How are we thinking more holistically as a system and really focus on the patient instead of kind of where that work usually falls?
Yeah, and I think I would add on to a comment of where the work usually falls. I think where we're really getting creative, and then Dave, I'll circle back to your original question, is we don't necessarily have a facility to help us with a lot of the centralization that we're looking for from a medication distribution standpoint as we think about implementation. So a lot of what we're doing is how do we still push forward with Systemness and still really maximize on economy of scales without necessarily making that investment today. So a lot of our exercises is really taking each of our programs and understanding what our capacity is. So we know we're going to need to think differently, and we know we're going to need that space. So I think it's been a lot of partnering of what are our needs. Before, I can tell you 4 years ago, we were talking about a lot of our workforce coming in, even if it's our service center workforce that does 90% of their work on the phone. Now we get to really rethink that with where telemedicine has gone and virtual clinical models have gone, and now our footprint in our ask has changed and minimized. So I think there's a lot of dynamics to that, and just really pushing forward in regards to where that systemness approach. I think when we think about what barriers in really moving forward these initiatives and what could get in our way at times, I mean, it's very basic. It goes down to communication. And I think it's really important as the pharmacy leaders to just be constantly connecting and understanding what is being asked of other departments or areas. And again, figuring out where you can partner, where is everybody's motive and what's being asked of them, and where there's collaboration. I think that's what's helpful. And I think just also, I go back to the ability to speak multiple languages. It also means just because we can speak multiple languages, we can't do it all by ourselves. So I think that's another really important aspect too, that I've gained a huge appreciation for as you're talking through these initiatives, the importance of really inviting other individuals at the table to really talk through what that means from a pharmacy program perspective, but also getting diverse perspectives to really help you push that initiative forward. And then the other piece is the buy-in. So most of the system structures do have system executives, and just making sure that there's that close connection and communication in regards to helping overcome some challenges and barriers so that you can be able to push forward.
Melissa, I just want to add on to your comment about relationships, because I would echo that is so incredibly important to the success of the pharmacy enterprise. I actually meet with site executives quarterly for all of our sites to talk through, here are the biggest pharmacy initiatives you need to be aware of and what's on my horizon. Because I know many of them may not necessarily be in constant touch base with their local pharmacy leader. And so as the pharmacy executive for the system, I feel it's my job to also advocate for that local leader. And so oftentimes I'm able to bring up issues that local leader is not able to resolve, and we're now able to get to resolution. And so I think for anybody who's at a system level role, building those relationships is really vital to being able to push the pharmacy objectives forward and help support more locally as needed when the teams do need that support.
We haven't called this out specifically, but I think the importance of being able to influence, like the power of influence, is just so key in our roles. We're not going to have direct oversight over every program, but we do have the creative thought process to know where pharmacy programs can complement an initiative and be part of the strategy. So I think building relationships so that you can influence the path of how maybe other colleagues get there is also really, really important.
Yeah, I'm just floored by like how much the skill set of chief pharmacy officers and senior leaders in pharmacy has evolved just in such a short amount of time. It feels like we just got comfortable with the CPO title, and I just think about just the number of skills that you've both laid out today that contemporary pharmacy leaders need to have. And it's awesome to speak with two of them, two good examples of the broad skills that one needs. And I think it would be a good idea then maybe to wrap up our time to get together as innovators to talk about, like, what do you guys think are the last challenges or unique opportunities that are on your radar that you think our audience should really be thinking about? Staci, if you don't mind starting, just like, hey, what's on your mind?
I think there's a couple of things. One is the rapidly shifting environment from a 340B perspective, in addition to the payer landscape. And so really starting to partner with your government relations / payer relations teams and thinking through how can we, again, pharmacy be a solution to what they're seeing. Layered on top of that, I think of the retail space and the PBM space. That is also a rapidly changing environment. I just saw Mark Cuban and Intermountain Health are partnering, right? And so like our landscape of where we have market share is rapidly changing. And so we need to be prepared for that and thinking through how will this impact our patients. I know many of us aren't looking to conquer the world in terms of servicing patients, but for those patients who do come to us, how can we be that solution? So those are three, I guess, areas that I'm currently working on to think through where pharmacy can be solutions to those problems. Melissa, I don't know where your head is at this point in time.
Do you have 3 or 6? Let's see.
Definitely very buried in your top 2 right now as I oversee our ambulatory pharmacy programs. But I think what I would add to that too is when we think about what is driving a lot of health systems, they're not only focused from a community hospital and acute care hospital, but they're also focused on building programs to really support the patient outside of the hospital and the longitudinal management. So I think for me, what I think is important as you're building pharmacy programs and wanting to be that creative solution and increasing access to pharmacists for patients is really having a solution for every episode of care. And I think that's been really important. And it goes back a little bit to what you were stating with the payer landscape, because that is shifting, right? That is no longer going to be an option for us to decide what the right side of care is for our patients. We're seeing payers more and more mandated every day. So I think knowing that that's coming and being able to anticipate that and then having a solution in place so that you can continue to care for your patients, because there is that value story that if you have all your programs within the system, it does provide that frictionless care and that integrated approach. So I think that's something that I would add on to Staci's top 2 or 3.
Well, thanks both. I'll let Jim wrap us up. A great conversation. I appreciate it.
Yeah, this was some great information and discussion. So again, thank you all for your participation today. And thanks to everyone for listening. And again, happy Pharmacy Month.
Thanks, Jim. Happy to be here.
Happy Pharmacy Month.